So next video is about anastomosis principle. This is video 2 for chapter 12. How does an anastomosis heal? Talk me through the various stages. So anastomosis heal in three stages. One is lag phase, which is acute inflammatory response, which clears the wound of all debris. And second phase is proliferative phase, that stays 3 to 14 days, in which fibroblasts proliferate and immature collagen is laid down. And third last remodeling and maturation phase, that's day 10 onward, in which collagen remodels. So collagen is vital in determining the intestinal wall strength. So next question is, talk me through hand sewn anastomosis. So the points, so both ends of the bowel should be healthy, adequate exposure, tension free, size matched, non-crushing clamps, luminal cleaning with betadine, 2 stay sutures, and then I will do single layer extramucosal with absorbable either Vaquerel or PDS, and then mucosal apposition, air leak test, and omental patch. And the principles for best osmosis: meticulous surgical technique, adequate blood supply, minimize contamination, tension free, inverting edges, healthy tissue for apposition, and ensure patency. And when do you perform a staple versus hand sewn anastomosis? Again, in this book is written that in Cochrane review, if you are doing an anastomosis in the ileocolic part of the bowel, so staple has less leak rate, that's 6.7% as compared to the hand sewn. And in the colorectal anastomosis, again, there is a Cochrane review in 2012, which is showing there is no any superior technique. Both have equal results. And what are the risks for anastomotic leaks? So it is divided into 4. So technical factors, patient factors, and then it mentioned acceptable leak rate and colorectal. So technical factors are adequate blood supply, tension free, minimal contamination. And patient factors: malnutrition, chronic steroid use, diabetes mellitus, malignancy, radiation chemotherapy, hypertensive shock, emergency surgery. The leak rate is ranging from 3 to 6% for ileocolic or colocolic anastomosis. And colorectal below the petroleum reflection has high leak rate that ranges between 10 to 20%. There are a few meta-analysis retrospect. There are some studies which are claiming that if you do a defunction, the leak rate go down, but actually it's only the consequences of leakage anastomosis which can be controlled by giving defunctioning. Otherwise, the rate of leak is not going to settle. So next topic is asepsis and antisepsis. So surgical abscesses is absence of microorganisms within the surgical field, and antisepsis is the technique by which we achieve this. And there are antiseptic solutions which we paint before starting the surgery. And then is the sterilization. So it's a technique to destroy all the viable microorganisms, spores, and viruses by heat, chemical, or radiation. So what are the principles of asepsis? So principles, we call it care bundles, combining both patient and surgical factors. So patient should have hair removal on the day of surgery with a clipper, prophylactic intravenous antibiotics. And surgical team factors: scrubbing with disinfectant, choice of skin prep, wearing sterile gowns and gloves, and draping to surround the sterile field, and laminar airflow, and sterile instrument, and non-touch technique. Do you routinely wear masks and visor in the theater? Yes, for my safety as well as for the patient safety. Well, how is surgical equipment sterilized? So surgical majority of the instruments and drapes are sterilized using an autoclave, which is a saturated steam at high pressure at 134 degree pressure of 2 for holding for 3 minutes. And this kills the organism, including viruses and heat resistant spores. And then other method is dry heat sterilization, is used for moisture sensitive instruments and those with the fine cutting edges. The tools are heated to 160 degrees for 1 hour. Autoclave, dry heat, then ethylene oxide, and then is the gamma radiation for catheters and syringes. These are the plastic things. So what are the difference between chlorhexidine and povidone iodine? So let's talk about chlorhexidine. Chlorhexidine is strong with bacteriostatic and bactericidal properties. It has a good cover against gram positive, moderate activity against gram negative, some activity against pseudomonas, poor activity against spores, fungi, and viruses. But it's non-toxic to skin and mucous membranes, inactivated by soap and pus, acts by disrupting medicinal walls, and its effects persist for up to 6 hours. So it comes in two strength. One is 4%, one is 0.5%. So 4% is a detergent, heavy scrub, scrubbing up, rapidly active, persists with cumulative effect even under the gloves. It's how we do a scrubbing. And other one is 0.5% in alcohol at the skin prep. So must be air dried prior to using diathermy. So this was all about chlorhexidine. Next is povidone iodine, is a stable complex of polyvinyl pyrrolidone and elemental iodine. Good and broad spectrum against gram positive, negative, spores, fungi, viruses, including HIV and hepatitis B, bactericidal. Easily inactivated by organic material like blood, feces, and pus. Must be used at optimum freshness, acts by oxidation and substitution of free iodine, does not have a prolonged effect when used for scrubbing. What do you use for skin prep? So we normally use povidone iodine 10%, but nice guidelines are that there should be chlorhexidine alcohol should be used. Next, it's mentioned about benign skin lesions. So a 76-year-old man comes to your clinic with a raised greasy plaque on his back. What is like the diagnosis? So it's seborrheic keratosis. Next is a 67-year-old male presents with a raised lesion on his cheek with a central horn. What's the diagnosis? It's keratoacanthoma. And then is what's bone disease? It's a premalignant intraepidermal cancer, and if we don't treat it, it can convert it to squamous cell carcinoma, and it should be excised with 5mm margin. And when seen on the penis, vulva, oral cavity, or it is known as the erythroplasia of Queriot. A 22-year-old girl presents with multiple cutaneous soft nodules and brown patches on her skin. What is most likely diagnosis? And so it looks like she got neurofibromatosis. It's a familial disorder, and there are 4 types of neurofibromatosis. Number 1 is the one which this girl has. It's also called von Recklinghausen disease. Patients have neurofibromatosis, more than 6 caveolate spots, axillary fleckling, and leash nodules. And then is neurofibromatosis type 2 that happen in the central nervous system, in which can damage the cranial nerves, like schwannomas, acoustic neuromas. And type 3 is schwannomatosis, which is very painful and very rare. And type 4 is plexiform neurofibromatosis, which are infiltrative lesions on the head and neck. What complication can neurofibromatosis give rise to? So it's again pressure effect, compressive neuropathy, deafness, sarcomatous transformation, especially in von Recklinghausen disease, intra-abdominal effects like obstruction, chronic gastrointestinal bleed, and skeletal changes can cause pseudoarthrosis and kyphoscoliosis. How would you classify benign pigmented skin lesions? So again, they develop from melanocytes in the epidermis and dermis. Thank you.